Okay, welcome to this presentation on improving clinical reporting in audiology. One of the most important aspects of providing healthcare is reporting the results of an evaluation or treatment outcome. The fundamental challenge of reporting is describing what was found or done in a clear and concise and consistent manner. This presentation focuses on moving from simply documenting data to providing true diagnostic insight. It's crucial to distinguish between documentation and reporting. Documentation is the preservation of examination and test results in a medical record. Reporting is the summary of that documentation. Thoroughness is an important attribute of documentation. Succinctness is an important attribute of reporting. For example, detailed tympanogram metrics belong in documentation, while the summary phrase, quote, normal middle ear function, unquote, belongs in the report. A retrospective study of 6,000 audiologic reports revealed an incongruence in explaining findings in about 25% of cases. This means the referring physician explained the findings in the record differently than the audiologist's diagnostic intent. Otolaryngology providers receive over 100 reports per day from various laboratories and specialists. These providers must contend with an enormous amount of information and need synthesized answers, not a recount of the clinical process. The SOAP note format was originally devised for medical reporting in 1968 by Dr. Lawrence Weed. He was brought up in the previous lecture on documentation. Dr. Weed suggested that a medical record should be problem-oriented rather than source-oriented. The SOAP format was originally designed to expand a patient's ever-updating problem list, but today the SOAP note has devolved into a chronological diary used to structure patient encounters rather than supporting a problem list. Chronological SOAP notes force referring physicians to wade through subjective history and raw data before reaching the definitive diagnosis. Reports should be structured to emphasize the important outcomes first. The assessment and plan components of the SOAP note are of greatest relevance to the referral source. The APSO note, different format, SOAP note just in a different format, places the assessment and plan first, followed by the subjective and objective data. Patients and referring providers primarily want to know the answer to the central question, is there a problem? How the clinician came to the conclusion is generally at the bottom of the list of their concerns. The level of structure within a report can vary considerably. The continuum moves from free text or prose to semi-structured formats, templates, and finally to itemized checklists. Evidence from other consultative specialties shows that itemized checklists are preferred by referring physicians. Itemized reports have been proven to increase diagnostic completeness. So SOAP notes and notes of that like are semi-structured, kind of in between itemized reports and free text. So they're kind of in between. Complexity of language and grammar in reporting should be kept to a minimum. There's a negative correlation between linguistic complexity and the perceived certainty of the reporter. Providers prefer having detailed reports and want pertinent negatives documented to ensure the test was performed. So for example, if a certain finding was negative, you want to report that. Or if there was a certain complaint that was negative, they denied ear pain, you want to report that. If they had negative results on acoustic reflex decay, you want to report that. The most appropriate place for pertinent negative information is in the documentation section when it comes to the actual test results, not the core report. Consistently stating routine findings such as speech audiometric results consistent with audiogram trains physicians to filter out and ignore this information. Audiologists must highlight information only when its abnormality is potentially diagnostically significant to save the reader's attention for red flags. So unexpectedly poor word recognition in the left ear is an example here. It's bolded to highlight it. A hearing evaluation report can generally be divided into 4 functional areas of assessment. The first pillar is middle ear function, focusing on physical mechanics and impedance. The second pillar is hearing function, detailing sensitivity, configuration, and symmetry. The third pillar is retrocochlear function, identifying neurologic red flags and auditory pathway issues. The fourth pillar is communicative function, addressing the human impact and lived experience. A complete report synthesizes raw data into these 4 functional outcomes before detailing a plan. Assessment of middle ear function requires interpretation of admittance results in a complete data set. Diagnoses for middle ear function should clearly state conditions such as normal, increased stiffness, increased mass, perforation, or negative pressure. Hearing function is described using vital pieces of information including degree, type, configuration, and symmetry of the audiogram. Asymmetric hearing sensitivity should be highlighted only when the asymmetry is diagnostically significant. Information regarding meaningful changes in hearing status compared to a baseline evaluation is an important component of the diagnostic picture. So if you had a mean hearing sensitivity decline of 6 dB or 10 dB, that I would consider meaningfully significant. In the vast majority of cases, speech audiometric results are consistent with the pure tone audiogram. When speech recognition thresholds and word recognition scores are predictable, they should only be documented, not reported. So in the document section, in the results section, not the summary section, in a way, you could put it that way. So not reported, to avoid reader fatigue. When word recognition scores deviate significantly from what is predicted, speech audiometric results become an important component of the diagnostic picture. Action must be taken to highlight unexpected asymmetry, rollover, or binaural interference explicitly in the assessment portion. The referring physician relies on the summarization of retrocochlear data to determine the strength of evidence for next steps. Abnormally elevated acoustic reflexes indicate potential eighth nerve pathway pathology. Significant auditory adaptation on reflex decay testing requires physician review for MRI or ABR ordering. Word recognition significantly poorer than expected points to a functional or retrocochlear anomaly. These minor signs dictate major steps and must be summarized explicitly. So you can see here on the side, on the caution section, abnormally elevated acoustic reflexes, significant auditory adaptation on reflex decay, word recognition significantly poorer than expected, or significant signs of asymmetry, indicating high suspicion for retrocochlear involvement. Another facet that we don't talk about as much is communication function. And the communicative function refers to how well patients are able to communicate given their hearing loss and ability to understand speech. This is often left out of reports. This assessment takes into account the patient's self-reported function and their unique personal communication demands. Adult communicative function evaluates varying degrees of dysfunction and factors in the benefit of amplification treatment. Pediatric communicative function relies heavily on identifying risks to speech and language development. And you can see this goes on a scale from normal to severe dysfunction, assessed with and without treatment for adults, and it's typically assessed with treatment for peds because you typically will have amplification for any degree of hearing loss in children, at least sensorineural hearing loss. Recommendations are based on patient history. Audiometric findings, communication impact, and patient preferences. Medical action recommendations include audiologic consultation for middle ear disorders or obtaining medical clearance for surgery. Audiologic interventions encompass hearing aid selection, cochlear implant evaluations, bone conduction implant devices, and tinnitus treatment. Further diagnostic recommendations may include diagnostic ABR, vestibular function testing, or auditory processing evaluation. For electrophysiology, the rule is to provide a binary conclusion up front, such as normal versus abnormal, followed by predicted thresholds. For auditory processing, the rule is to state the functional deficit immediately, followed by actionable environmental or technological recommendations. For functional hearing loss, the rule is to report only the accurate results. The phrase behavioral measures inconsistent with objective measures clearly communicates that outcomes are not as expected with a functional hearing loss. The raw data represented by complex charts and graphs often acts as noise to the referring provider. The signal is the clear synthesized outcome, such as right ear, normal middle ear function, and moderate sensorineural hearing loss. Planned binaural amplification. The greatest value an audiologist provides is not in gathering the data. The true value lies in having the expertise to distill raw clinical data into a clear and concise and actionable story. That's all I have on this presentation.